Hi, my name is Leo from McKinsey & Co, and today I'm presenting this project of supporting healthcare in Vietnam through staff mentoring, training and program delivery and seeking your approval for funds. So now I'm going to talk about the purpose of this project. First of all, the healthcare system in Vietnam is lacking experienced medical staff. The healthcare system in Vietnam, in terms of workforce and quality, is currently poor and insufficient to meet manpower norms and practical needs. The number of medical staff in Yin Dang, for example, collectively is only 85 members, serving over 54,000 inpatients and over 131,000 outpatients a year. Overcrowding issue has been created as a result of that shortage, and due to the lack of clinics and hospitals and also low competition from private sector, with only 6% of all healthcare facilities is privately owned, many Vietnamese patients have no choice but to travel overseas for medical treatment. The health minister in Vietnam revealed that around 40,000 wealthy Vietnamese left the country for medical treatment in 2018, spending over $2.9 billion annually in neighboring countries. Improving the quality of treatment through training existing staff to meet the Australian and international standards, and this is as a result will minimize the risk of chronic diseases by following early intervention approach. Majority of hospitals in Vietnam are decentralized, and each hospital tends to follow their own standards. An electronic health record EHR will be utilized to communicate with other hospitals. One of the aims of this project is to create a stronger relationship between the two countries, which will also reflect on trade volume. Vietnam is Australia's 15th largest trading partner at 12.8 billion a year until 2017, and with further investments, this figure is likely to increase. Aiming to achieve the following objectives during and post the completion of this project. The rapid growth of health insurance companies stimulated investors to finance private clinics and hospitals, especially in highly populated cities. The growing GDP is also encouraging and inviting for local investors to ride on foreign investors' achievements to gain independence. After the government reform in Vietnam, the poverty rate dropped down gradually from 58% in 1993 to 28% in 2002. And from 14% in 2008 down to 12% in 2011. In approximately 2 decades, it is predicted that about 28 million people to have been lifted out of poverty. Investing in Vietnam will sustain transparency and prevent government corruption, which at the end serves Australia's interest. Some other global benefits will also arise while improving Vietnam's healthcare system, such as combating serious diseases like HIV, AIDS and Ebola. Australia has partnered with Clinton Foundation to contain the spread of those diseases in 2006. Implementing an innovative system that facilitates the process of keeping and maintaining patients' records and information technology has been great impact on improving quality and safety in addition to mitigating the costs. Jobs opportunities will be created as a result of this project. Vacancies will be available for university graduates from various disciplines such as accounting, business administration, medicine and nursing, which slightly assist in reducing unemployment rate. After exploring the purpose and the objectives of the project, now we need to address the project importance and what problems it solves. Inexperienced, low-skilled medical staff is a gap contributes into creating worse consequences, such as offering wrong medication and developing solutions to the wrong problem. And the lack of Vietnamese government investments in that area widens that gap. Lack of training and support leads us to another problem, which is shortage within the workforce. The number of physicians in 2015 is around 8 per 10,000 population, and that ratio is relatively low when compared to other countries in Southeast Asia. and with a population growth rate of 1%, then the workforce shortage will become a top priority for the healthcare system. The overcrowding issue is a consequence for the other two. It is an issue directly affect bed occupancy in hospitals and will prevent those more in need of urgent access from receiving a proper treatment. And that's because of patients' queues and pressure on healthcare resources. Finally, when medical staff facing an increasing number of patients, in addition to the inadequate training they received, then the quality of treatment will be compromised. Poor quality has worse implications such as spread diseases or tackling chronic illness, and in some cases, an increase in mortality or death rate. To justify the need for funds for this project and to determine why we have chosen Vietnam in the first place, we need to collect some data, statistics, and facts to reveal some signs of previously discussed problems. Now we are looking at the top 10 causes of death in Vietnam and how the likelihood of those causes increased over the period 2007 till 2017. The presented table shows the most alerting figures for the following diseases: diabetes, heart diseases, lung cancer, and chronic obstructive pulmonary disease, COPD, which is a common lung disease. Those figures highlight the urgent need for investments such as this project in order to reduce those growing percentages. Equally, one of the other measures that we use to evaluate population health and make it comparable to other nations over a selected period of time is the infant mortality rate. IMR is defined as the number of deaths in children under 1 year old per 1,000 live births for the same period. The IMR dropped from 19.1 in 2007 to 16.7 in 2017 in Vietnam, while in Australia it declined from 4.5 to 3 over the same period. The significant variance between the two nations refers to many factors, thanks to the world-class medical services in Australia, which have helped in preventing further loss of lives in newborns. To make our goals achievable, DFAT needs an assistance from other organizations. Each partner plays a significant role and complete each other's tasks. The Ministry of Health in Vietnam has accomplished healthcare provision through a system known as the Direction of Healthcare Activities. Also, they introduced a healthcare law to legislate a compulsory health insurance, which would cover 80 to 95% of health expenses. Working in conjunction with the Ministry of Health in Vietnam to facilitate an electronic health record, EHR, which will be utilized to communicate with other hospitals. The Ministry of Health has already initiated piloting the EHR system, which compiles patients' medical records into a single electronic database at 26 medical centers, and by the end of 2019, it will expand to include all hospitals and medical centers in Vietnam. And finally, the Ministry of Health will financially support the delivery of clinics and training of medical staff. RMIT University in Vietnam are likely to expect an increasing number of students applying for biomedical sciences and administration to meet the future job vacancies for the project. RMIT can support us by offering scholarship at Sarin South campus to attract more students who are interested in the medical field. The graduates will go through the training program to gain a valuable practical experience through working in the clinics. Monash University supports this project through providing qualified trainers and researchers. In the 2015, Monash University allocated over $172 million for medical researchers purposes. These genuine efforts will assist in combating the top 10 diseases that we discussed earlier. The World Health Organization, WHO, will enable international best practice and internationals to be implemented and provide support to the e-learning platform that will form a component of the training program. The WHO will also lend in vast reference base in network to the project, allowing for not only participants in the project to benefit, but also existing Vietnamese healthcare professionals working in the public healthcare system. Training staff and delivering clinics are not enough to make a tangible difference to the healthcare system. So we need to implement a system that has a proven record for its success, similar to what we have here in Australia. The Ministry of Health in Vietnam has already adopted the idea, so we need to make sure that our system is integrated and compatible with the existing one. Electronic medical record EMR will be used between the 6 clinics for sharing patients' information. EMRs contain information for editing or retrieving within a single healthcare organization, such as clinic, medical center, or a hospital. The second one is the electronic health record EHR, which contains information that can be reviewed, added to, and accessed across multiple healthcare organizations, so multiple hospitals or clinics. And the third one is the personal health record PHR, which is an electronic application through which individuals can access, update, and authorize what to share of their information when requested. Overall, the Australia is a member of the Global Digital Health Partnership, GDHP, an international collaboration of governments responsible for the delivery of digital health system under the WHO umbrella. It facilitates patients' health record exchange between its members. Implementing this system in Vietnam will qualify the country to join the GDHP association. So in this part, we are going to demonstrate what actually needs to be done and by when. This project consists of 2 phases to be implemented over a 2-year time frame. During the first phase of this program, medical staff were subject to comprehensive training in order to systematically develop knowledge, skill and behavior patterns to perform their tasks adequately. Equally, the training program targets existing workforce by offering in-class or e-learning resources to support national safety and quality health service standards and provide employment opportunities for both Australian and Vietnamese medical graduates. That's what we call onboarding. Therefore, by the end of 2019, we should have 100 staff members trained up and ready to gain experience. The establishment of 6 medical centers and clinical placement for medical graduates fall in the second phase. The placement process is to enable students to develop their clinical skills, implement theory into practice, learn and apply problem-solving skills, build interpersonal skills, and become socialized into the formal and informal norms, protocols, and expectations of the healthcare system. By the end of 2020, the clinics and the trained staff are ready to deliver services. Before we start operating the clinics, we need to ensure that our database is compatible with other care providers for referrals and communication. As discussed before, the Vietnamese Ministry of Health made a commitment to run the digital health system across the country by the end of this year. So the budget set for this project has factored all foreseeable costs over the life of the project. For both years, we need to pay wages for McKinsey & Co partners, support staff, and other staff required for delivery. To make the project feasible, McKinsey & Co have discounted the partner salaries by 50% as a contribution to the project. $200,000 of wages cost to be funded by DFAT, and another $200,000 will be shared by the other partners. The Vietnamese Ministry of Health has also committed to providing funding to support wage costs associated with the project. Please note that the staff wages for the clinic's professionals have not been included in our budget, as they are volunteering as public servants working in the broader healthcare system in Vietnam. The research and training for 100 staff members will require a fund of $200,000. Half of the amount will be charged to DFAT. The WHO will support through cash and in-kind contributions, in addition to any cost associated with e-learning and modules. And finally, the travel cost, including flights between the two countries, and this will be shared between DFAT and Vietnamese Ministry of Health, plus domestic travels between staff accommodations and working place. So the total for the first year of the project will cost $650,000, and that makes 50.7% of which need to be funded by DFAT and 49.3% by the WHO and Ministry of Health. So on year 2, well, the second year sees the delivery of the clinics requiring more funding than the first year to cover wages associated with running the clinics, so it will cost $300,000 more than the first year. As we can see, the research and training costs will continue over year 2 at the same cost as year 1. The equipment costs in year 2 are for assisting in the setup of the medical clinics, including IT and software. The Vietnamese Ministry of Health has committed to providing facilities. However, additional fit-outs will be still required. The total cost of the year will be $1,090,000. 47.7% of that will be funded by DFAT, and the rest between the WHO and Vietnamese Ministry of Health. At the end, and by implementing this project, we are expecting the following outcomes. First of all, beds occupancy. Beds occupancy should reduce as a result of utilizing sophisticated software and smarter database system. Our target is to drop the rate from 120% to below 100, which is a normal rate. This project will also contribute to the Vietnamese healthcare system as a whole through higher level training and innovation. Third, both countries will reap economic benefits as a result of implementing this project. By creating job opportunities will assist in reducing the unemployment rate. Therefore, more tax contribution will be generated to both governments. Furthermore, building medical centers and workforce stimulate investments in the surrounding areas. Community wealth building, CWB, and the circular economy are tools of development that set local stakeholders on top priorities. They aim to keep wealth circulating within local communities, as staff who live locally also spend locally. And finally, taking the proactive steps to contain the spread of diseases such as AIDS and HIV help protecting us here in Australia.